Good morning, and welcome to the 2026 Alan M. Boyden Memorial Lectureship, hosted by the Providence Center for Healthcare Ethics in partnership with the St. Vincent Medical Foundation. I'm Kevin Dirksen, Director of the Ethics Center and the holder of the Andy and Bev Hansel Endowed Chair in Applied Healthcare Ethics. This morning, we're broadcasting live from Providence St. Vincent Medical Center. You can earn continuing education credit by being here in the room with us, by watching the virtual event, or by watching a recording. Our team will be monitoring the Q&A throughout the session. For those who are joining virtually, please submit your questions using not the chat function, which is disabled, but the Q&A feature, and we'll hold them to the end as time permits. Before introducing today's speaker, we would like to acknowledge an important milestone. This year marks the 25th anniversary of the Providence Center for Healthcare Ethics. Since its founding, the center has played a central role in advancing healthcare ethics here at St. Vincent and across the Providence footprint, as well as contributing to the field nationally and internationally. This means that we, and those who came before us and have supported us, share a deep commitment to providing patients, their loved ones, and those who care for them with thoughtful ethical analysis, guidance, and support in the midst of complex ethical medical decision-making. Crucially, the center's approach and method is not to train clinicians when to call ethics to make the hard decisions, but to learn how through ethics coaching, consultation, education, and vocational development. It is fitting to mark the beginning of our year-long celebration of this anniversary during the Boyden Lectureship, which similarly affirms the importance of thoughtful engagement with the moral dimensions of medicine. And now it is my pleasure to introduce our 2026 Alan M. Boyden Lectureship speaker, Dr. Alessa Coliani. Dr. Coliani is a writer, professor, and head and neck surgeon specializing in the care of patients with head and neck cancer at UNC Chapel Hill. She graduated from medical school at Johns Hopkins, completed her residency training at Massachusetts Eye and Ear Harvard Medical School, and did her fellowship in head and neck surgical oncology and microvascular reconstruction at Vanderbilt. In addition, she completed a graduate degree at the University of Cambridge in history and philosophy of science, studying the phenomenon of intentionally ineffective CPR, sometimes called slow codes. A friend of the local bioethics community, Dr. Coliani practiced here in Portland at OHSU before returning to North Carolina, yet, as I might imagine, leaving any lingering Blue Devils gear from undergrad days in favor of Carolina Blue. She has been using writing as a way to process difficult or ethically questionable issues in medicine since her time as a medical student, and publishes essays about medical and surgical training and practice, both in the medical and lay press. Her essays have been published in the New England Journal of Medicine, JAMA, the New York Times, and many others. And now, won't you please help me welcome Dr. Alessa Coliani.
So good morning. Thank you so much for having me. I am really honored to be here, and it's been a long time coming. I'm not exaggerating when I say that I've looked forward to this day for over 3 years. Since Kevin first approached me about this, many things have changed. So I had a daughter who's now a rambunctious 2-year-old, and I moved across the country from Portland, which I loved, to North Carolina, where my husband and I are now a year and a half into new jobs at a new institution. And I'm really excited to be here today, talking with you about something that's been important to me kind of throughout my medical career, but particularly now as a head and neck surgeon. And so the title of my talk today is, quote, ultimately, it's about identity, narrative medicine, personhood, and moral imagination. I have no disclosures other than the fact that I have a big dumb dog and a big dumb cat who really like each other, and they actually nap together. That's not a staged photo. And then this is that aforementioned rambunctious 2-year-old on a hike with my partner in the North Carolina mountains. So as I was learning more about the namesake of this lectureship, I was surprised and pleased to learn that Dr. Boyden was a general surgeon here in Portland. And I went down a little bit of a rabbit hole when I found 2 presidential addresses that he gave to prestigious general surgery societies in 1974 and 1977. In both, he extolled the virtues of humanities education for all doctors, but particularly for surgeons. And in his 1974 address, he quotes an 1897 speech by none other than Sir William Osler, the founder or father of modern medicine. And he says, quote, "By the neglect of the study of the humanities, which has been far too general, the profession loses a very precious quality," a sentiment which I can't help but agree with. And he really rails against the idea of subspecialization and premature specialization, noting that the humanities education is critical for the development of good surgeons who are also good humans. And I was tickled to see that head and neck surgery even made a shout out as he was worrying about the subspecialization of the education of general surgeons. So he writes, "I think you will agree that many physicians today are limited by too narrow a background in scholarly pursuits, and that in general, our finest men and women have been those with wisdom gained from a broad educational experience in the humanities as well as science." I think Boyden was really prescient on that last point about subspecialization being a danger to general medicine and general surgery, because the subspecialization of medicine has only really continued and intensified since 1974. And I think the impact of that further specialization is the further divvying up of the body into tinier and tinier quadrants of expertise. In a recent cartoon from the New Yorker, subspecialization reaches the realm of the absurd. So I'm not sure if you can read this, but it just says, so the foot guy sent you here. Well, I'm a knee and upper shin guy. You're going to have to see the lower shin, upper ankle guy. I think that impact is felt particularly acutely by patients who feel now more than ever that they are nothing but a body part or an organ system to their treating physician, and that no one might be seeing the whole picture or the whole story. And so that brings me to the purpose of my talk today. So I want to talk about identity and personhood in the context of illness and how those ideas are challenged by illness. I want to talk about narrative medicine and its relevance to ethics and discuss narrative inquiry as a method of maintaining moral imagination. And I'm going to do that through the lens of a patient that I saw in one of my first weeks of practice in North Carolina. So last year, maybe a month or two after I'd uprooted my life, moved across the country with my then 10-month-old, I walked into a clinical encounter with minimal information. So for those of you who are clinical, often when I get referrals, they have a whole packet of information. A biopsy, since I'm a cancer surgeon, often that biopsy shows a head and neck cancer, or sufficient concern for some kind of malignant process that the patient understands why they're seeing a head and neck oncologist. And this patient had none of that. There was a picture of a tongue lesion in the referral from her dentist and no other information. So I figured I would walk in, do a quick biopsy of the lesion, and that's where our clinical encounter would start. But before I walked in, my nurse came out and got me, which is never a good sign, and said, "This patient is really upset. She's telling me that she has cancer. She's crying." So I go in. I see a woman my own age with her husband, and they both look absolutely stricken. They tell me that she's had this lump on her tongue for 3 months. Her dentist biopsied it and called them last night with the pathology results, which I do not have, to tell them that it's a very aggressive form of tongue cancer with abysmal survival rates. So I call her referring physician, and luckily he picks up and explains that the pathologist who works at my institution and who has not finalized the pathology report yet was so concerned that the pathologist had called him the night before so that he could get her in with an oncologist very quickly. So this young mother of three, hairdresser, now has an aggressive cancer of the tongue. And at this point, the clinical visit shifts to something that I'm a little more comfortable with. I talked with her about surgery, which is the mainstay of treatment for these types of cancer. And surgery would include removal of the primary tumor, as well as a margin of normal tongue tissue, as well as removal of the lymph nodes in the neck. And the neck is precious real estate with lots of cranial nerves that do everything from move the tongue and face to innervate the shoulder to sensory input to the skin, innervation of the vocal cords and voice, and not to mention the fact that in order to do a neck dissection, you have to do a big incision on the neck. She was so anxious about her diagnosis that she was shaking, but as soon as I described the surgery, she calmed down, looked up and said, "I don't care what I look like or sound like. I want to be there for my kids." So we went through with the surgery, and intraoperatively, I was aggressive. I wanted her to be there with her kids too. So when I saw a lymph node that was very close to the nerve that controlled her lower lip, I didn't shy away from it. I took it out, even knowing that that nerve and others would probably be weak afterwards. And indeed, postoperatively, she did have some weakness of the shoulder from where I had dissected her spinal accessory nerve, and her lip from where I had dissected her marginal mandibular nerve. From the tongue tumor I removed, she was recovering fairly well, but she had a little bit of dysarthria and was having some trouble swallowing, particularly some spicy foods. But I remember walking into her hospital room after the operation and seeing how much less anxious she was than she had been when I first saw her in my office. Sure, she was dealing with some post-op issues, but she was also, she thought, moving forward with treatment of the aggressive cancer she'd been so unfairly diagnosed with. Now we're just waiting on final pathology to tell us whether she'll need postoperative radiation. And because of this aggressive diagnosis, I had already prepped her in the clinical visit that she was likely to need additional treatment like radiation or chemotherapy once she had recovered from surgery. But here's where the straightforward case becomes less straightforward. So normally pathology takes 7 to 10 business days to come back, but now we're 2 weeks later and I haven't heard a word. Seeing her in my clinic, she's recovering. Her shoulder's still weak. She's having some trouble picking up her young son, which is causing her some distress. Her lower lip function is improving and she's no longer drooling when she eats, which makes her pleased. And her tongue site has healed to the point where she can eat almost all consistencies now. But then I get a page from the pathologist and I know something's up. Hey, he says, something's not adding up here. I've had 5 other pathologists look at this and I don't think it was ever cancer at all. It's a really rare benign tumor with no metastatic potential. Okay, so what now? I discussed this with the patient over an hour-long phone conversation. As expected, she had a lot of questions, and her dominant emotion at that time was relief. She did not have cancer. I, however, was mostly terrified that I had maimed this woman for no reason. After all, cranial neuropathies are something we can tolerate when they're necessary parts of extirpating a malignant process, but very different when we're talking about benign disease. And in fact, this is something that I talk at length with my residents about, the fact that for me to take on the moral burden of operating on someone and potentially harming them in the process, I need surgery to be the only option for my patients. The risk-benefit ratio has to very squarely motivate surgery. So the tumor itself and the way that this case unfolded was unusual enough that a few months later, or a few weeks later, I got another email from the pathologist saying that they wanted to present this case at a national pathology conference and whether I would be okay both with that and with asking the patient for permission to present the case. And this is what they sent me. It's a pretty fairly cut and dry clinical case. 37-year-old non-smoking female, slowly growing firm, non-tender 1 centimeter exophytic tan lesion on the left lateral tongue. Incisional biopsy was performed, showed some atypia, excised the lesion, and supported a diagnosis of benign sialadenoma papilliferum. So when I read this, I couldn't help but feel that this rendering of the case had completely missed the point. It was devoid of any mention of the original diagnosis, this aggressive cancer that had motivated the surgery. It contained none of the anxiety and fear that my patient had suffered in the weeks between her diagnosis and surgery, and nothing of the discrepancy between the biopsy result and the final pathology. The case report was clinically accurate, but not narratively accurate. So what do we miss when we exclude these kinds of questions of narrative, identity, personhood, and story from the clinical encounter? What do we miss when we exclude biography? So this brings me to the concept of illness, not just as a biochemical or physiological disruption, but also a biographical disruption. And this was an idea that was first espoused by sociologist Michael Burry. In the late 1970s, he conducted a series of semi-structured interviews with patients who were in the process of undergoing diagnosis for rheumatoid arthritis. And he argued that the findings showed that chronic illness impacts the structures of everyday life, not just the patient, but their families and wider social networks, and disrupts the normal rules of reciprocity and mutual support. He also noted that medical knowledge and medical treatments, which we as practitioners know are neither absolute nor all powerful, but he argued that this limitation actually necessitates the incorporation of biographical, experiential, and personal knowledge into the patient's conception of their disease. He writes, the realization that medical knowledge is incomplete and that treatment is based on practical trial and error throws individuals back on their own stock of knowledge and biographical experience. The search for a more comprehensive level of explanation and a more certain basis of coping with the illness is often a long and profound one. He describes one of his interviewees who was a roofer who became profoundly disabled as a result of his rheumatoid arthritis, and who described bitterness and resentment at the unfairness of his disease and depression and pain in the interviews with the sociologist, but he never talked to his doctor about these feelings and practical hardships. And I would argue that not just chronic illness, but any acute and severe illness has the same disruptive biographical potential across multiple spheres of a patient's identity, personhood, and biography. Our patients with acute illness experience losses beyond morbidity and mortality. They can lose essential aspects of their humanity. Head and neck cancer is particularly assaultive to identity and even to personhood. So head and neck cancer can involve altered, both the cancer itself and the treatment for the cancer can alter the way somebody speaks, swallows, recognizes themselves, and can lead to significant scars and disfigurement that also disrupt somebody's personhood. And so what do I mean by personhood? So briefly, personhood is a holistic and biographical way of considering an individual. It's distinct from biological life and functional status. It's distinct from decision-making capacity. It has to do with ideas of identity and continuity of self, agency and authorship. What makes you you? And it includes your entire social network. So what roles do you play at home, at work, with your family, with your loved ones and friends? It's situational and relational, not simply intrinsic. Personhood is based on the story of you. And narrative medicine, I think, can help us remember and retain elements of personhood in the clinical encounter. So narrative medicine, broadly speaking, or I guess actually specifically speaking, narrative medicine as an academic discipline was founded in the early 1990s by Dr. Rita Sharon, who's an academic internal medicine physician at Columbia, New York. Decades into her practice, she felt that she and her patients were lacking a dimension to their relationship that went beyond diagnosis and treatment. And she had the somewhat radical idea that literature could help. So she pursued, in the middle of her career, she pursued a degree in English literature at Columbia, and collected some similarly minded doctors and practitioners founding this nascent field. And so she describes narrative medicine as medicine practiced with narrative competence to recognize, absorb, interpret, and be moved by the stories of illness. And her colleague, Sayantani Dasgupta, who's a writer and pediatrician at Columbia, elaborates that we want to train clinicians to elicit, interpret, and act upon the stories of others and hold in equal stead multiple ways of knowing, the scientific and the storied, the informational and the relational. So importantly, this is not to supplant or replace the scientific and clinical aspects of medical care, but rather to hold them side by side, and to recognize that each gives us something different for the clinical encounter and for the care of our patients. Narrative medicine has really exploded since its inception in the early 1990s. It includes now multiple degree programs, and they've even graduated their first few PhDs or MD PhDs in narrative medicine in Columbia. But when you think about it, narrative and narrative medicine is not just this degree program, it's really central to the medical work that we do every day. Listening to, responding to, and telling stories is essential to what we do as physicians and healthcare workers. The first thing we do when we see a patient in clinic or the emergency room is to take their history. So we try to understand why this patient is here seeing us. Or we listen to our trainees present their assessment of the patient's story at rounds, weaving it into a narrative that encompasses symptoms, diagnosis, and treatment. When we're writing our notes in the medical record, we're telling the story of the patient's trajectory towards restored health, towards a diagnosis, towards an ending. And when we dictate an operative report, we're telling the story of what we did, how we did it, and how we might have been surprised along the way. So understanding stories from a perspective and point of view from a narrative standpoint is a big part of the work that we already do every day. And so seen through this lens, we can frame the clinical encounter as a narrative event. Some clinical encounters might even rise to the level of biographical events, events that add a chapter or a new act to the story of you. Every encounter asks and answers, even implicitly, who are you now? Who gets to speak? Whose story are we telling? And what kind of a future is imaginable? And way that we can frame these as narrative events, conversations that we're having are already narrative events. So framing prognosis or conducting a goal of care conversation or making surgical recommendations based on a diagnosis is also a narrative event. And small narrative choices can have large ethical consequences. I always get a question about how we're supposed to include narrative medicine in this already congested clinical encounter. The time pressure of modern medicine is well described and really makes this seem impossible. Like there's no way we could possibly add another element and thing we have to care about into this 15-minute clinic visit. But my point here is that the clinical encounter is a narrative event. Regardless of whether you explicitly acknowledge it or not, your clinical encounter is part of your patient's story and your story as well. And so giving some attention to narrative inquiry in your encounters can be helpful. So narrative inquiry asks not just what happened, but what does this experience mean to the person living it? And how is that meaning formed over time in relationships and in place? Narrative inquiry studies human experiences through stories. And I would argue that it can increase our capacity for moral imagination. So moral imagination, our ability to perceive patients and ourselves as full moral agents with complex lives, values, and possible futures. I think narrative medicine sustains this capacity by slowing clinical judgment, by restoring authorship to patients, by tolerating ambiguity and sitting with suffering, and preserving openness in a system that really pressures clinicians towards reduction and certainty. And I think this is important because stories are one of the ways that we understand ourselves. So we understand ourselves through our past, our present, and our imagined future. And illness disrupts this narrative coherence. You might consider a patient who's just received a diagnosis saying, "This isn't the life I thought I was living." And as clinicians, we have an important part in these stories. We can be witnesses to biographical rupture. We can be characters in a chapter. We can be co-authors of a new story. And I would argue that cases or care rather that ignores these narratives risks erasing the person or making someone a character in their own story rather than the narrator. Even small narrative choices that we make, like the words that we use, can have a very outsized impact on our patients. And here, Daniela Chamas, who's a palliative care medicine physician at UCSF, I think says it best. And this whole essay is amazing, so I would highly recommend downloading it and reading it. But she concludes with this idea that words matter. Is somebody a patient, a victim, a survivor, a burden? What does it mean to be a fighter, to do everything? Did we give up on a loved one, or did we honor their dignity? Did we choose to not resuscitate, or did we choose to allow a natural death? Whether intentional or not, clinicians are often an important source of vocabulary that these writers draw from. With each choice of words, clinicians affect narratives, and some words wield particular power. Just, for example, has the power to diminish. How boxed in does one feel when their identity slips into just a patient, just a diagnosis, when hospice becomes just about dying rather than living one's final days to the fullest? I'd like to take us back to the patient from the beginning of my presentation. So just to illustrate kind of how illness challenged her personhood. So before this diagnosis and surgery, she viewed herself as a devoted mother, and now she has difficulty lifting her son because of the shoulder weakness that was caused from her surgery. She viewed herself as a generous spouse, but now she's unable to contribute equally to her household, and her husband is having to take on a significant burden of raising their 3 children. She was a talented cosmetologist and hairstylist, and now she has pain when she lifts the hairdryer, which is integral to her job. She's an attractive young woman. Physical appearance is important both to her work and to her life. And now she has a visible scar and facial nerve weakness and an asymmetric smile. She was an articulate adult. Now she has difficulty with speech and swallowing that was immediately postoperatively. Luckily, this is improving, but this was a big change for her. And just to add another layer, all of this was tolerable when she was a cancer patient, but what about after the pathology revelation? I'll add that this also challenged my own biography and narrative. So I went from being a good surgeon, a careful oncologist, a thoughtful doctor, all of ways that I conceptualized myself and my practice, to someone who had made a very rash decision based on imperfect information and had maimed someone my own age for no reason and had disrupted another person's life unnecessarily. Because my patient isn't here to provide her perspective directly, I want to switch gears here and talk specifically about identity through the life and words of poet and head and neck cancer survivor Lucy Greeley. Oh, I'm so sorry. This is complicated. All to say that the emotional reactions that my patient had to her diagnosis and to the revelation and to her surgery were complicated. So initial relief gave way to confusion, anger, and anxiety. So what can I trust? Do I trust the original biopsy? Do I trust the final pathology? So coming back to this idea of illness as biographical disruption, the limitations of medical knowledge and treatment were brought into stark focus for her and weren't enough to kind of bring her back to a good sense of herself. So just that the meaning making of an episode can change over time. And I think being attuned to that is really important as clinicians. So now I'm going to switch over to Lucy Greeley. This is Lucy Greeley. She was a poet and memoirist, and her life and identity was really shaped by a childhood cancer that left her without half of her mandible. So at age 9, she was diagnosed with a Ewing sarcoma. She had a very disfiguring oncologic operation at age 10, followed by years of chemotherapy and radiation that took up a lot of the rest of her childhood and adolescence. And her adulthood was marked by over 30 attempts at reconstructive surgery, and this included the nascent field of microsurgery, which I practice now. She underwent a lot of experimentation by the best plastic and reconstructive surgeons of the time, but unfortunately, none of them were successful. All of her reconstructive procedures failed. And along the way, Lucy became a poet and author and wrote a very widely read and critically acclaimed memoir entitled Autobiography of a Face, in which she grappled with the way that having an obvious deformity alternately destroyed and defined her identity. And her story is a tragic one. So after her memoir and essay collections were published, she was left from all of her surgeries with significant chronic pain and depression, and she ultimately died in 2002 at age 39 of an unintentional opioid overdose. So in the coming slides, I'll let Lucy tell her own story. So in this passage, which appears in her autobiography of a face, Lucy's 10 years old, and she's about to undergo her first surgery, this original insult that left her with half of a jawbone. No one clearly explained to me what was about to happen. Mary, the head nurse, did call me over at one point. This is a big operation you'll have tomorrow. You know that, don't you? She looked me right in the eye. Do you know you'll look different afterward? Bizarrely, after they removed half my jaw, I limped. It was my first day up and out of bed, and I was going to traverse the entire 4 feet to the bathroom. This required a certain amount of preparation, of disconnecting tubes and wires. Why are you limping? They didn't do anything to your legs, chicken chops. My mother was watching the nurse helped me. I liked it when she called me chicken chops, the name she used with any of us when we were ill. My non sequitur limping seemed to amuse the nurse and my mother, and eventually it amused me. None of us understood that the body is a connected thing. So Lucy here verbalizes the interconnectedness of the body. Although this surgery didn't do anything to her legs, she limped thereafter, and I would argue that this is an illustration of kind of the completeness of a biographical disruption, that it impacts not just the organ system that's involved, but really the entire body. Here, Lucy is 16, and I chose this passage because it illustrates the clinic visit as a biographical or narrative encounter. And so here she's speaking with one of the physicians who would be one of her treating reconstructive surgeons. And I should mention that, prior to this, as an adolescent, having gone through a very difficult, adolescence is tough enough. Adolescents with half a mandible, I can't even imagine how cruel, the people that she encountered could be, and children could be. And she writes that she had essentially given up on the idea of having a normal life and had essentially given up on the idea of beauty. And so this defining clinical encounter is one of her first consultations with a plastic and reconstructive surgeon. So she writes, I would have to have a major operation followed by lesser ones to shape the graft, but Dr. Baker seemed to think that there was a good chance of achieving a, quote, near normal jawline. I can still see my father's reaction as he stood in the corner of Dr. Baker's office, listening to his words and beaming. I had never mentioned my fears concerning my face to my father, and in my solipsism, I had never thought that he might share my unhappiness. His joy made me feel better, although it also occurred to me that my face must really be as bad as I feared if he found such relief at the possibility of this surgery. So in this passage, you can see Lucy grappling with core issues of her own humanity and identity. Having had a very obvious facial deformity from a very young age, and having internalized all of the reactions that she got, the horror, shame, curiosity, other reactions from her peers and family, she had essentially rejected the norms of beauty that she felt she would never embody. She had basically refused to be defined by her face by ignoring it, and had kind of forgotten that it might also be a source of angst or anxiety for her loved ones. But in her father's reaction to the proposed surgery, she sees herself through a loved one's eyes. And for her, even at this very tender age of 16, the prospect of fixing her face was something that provoked hope and somewhat a paradoxical sense of guilt. Here again is another example of a biographical encounter in the clinic. And at this point, Lucy was in her late teens. And we'll notice the things that Lucy picks up on that make a difference for her in her forging of the relationship with this other reconstructive surgeon. Without the threat of chemo or dental work, being in a doctor's office seemed so simple and easy. As Dr. Conley examined me, he held my head in his hands, touching my face as no one else had in years. It was only then that I realized how guarded I had become about my face. Allowing him, simply relaxing and allowing him to touch me was akin to surrender, the closest I ever got to experiencing trust. After the examination, he sat down and spoke to me in the tone of someone speaking to a child, which served to both instantly destroy and strangely build the trust I had in him that I had felt only moments before. And this, again, kind of complicated paradoxical reaction that Lucy has both to the experience of being touched by another individual, but also then the patronizing tone that this doctor takes with her. So in the aftermath of her memoir being published, Lucy was interviewed on a number of talk shows. This memoir really took off, was very, very popular. You know, the 1990s were kind of a real, I wouldn't say renaissance, but maybe naissance of autobiographical content. And so this memoir really took off in a way that I think nobody expected it to. And so here I'm going to show you some video clips of her on Charlie Rose. Haha. Who obviously has become a more controversial figure than he was in 1994. But this is Lucy in her own words, and you can see her speaking about the impact of this writing on her.
Pain. It is about self-esteem. It is about image. It is about what else?
It's a book about identity and forming your identity, your idea of who you are, how you act in the world. You know, in the innate sense we have of who we are, and then that somewhat less innate, more mysterious sense of who we are, where our borders meet other people's borders, and how other people perceive us, and how we perceive them perceiving us. I think it's really a book about being looked at and being seen, and seeing yourself both through your own eyes, other people's eyes, and learning to tell the difference between those two sets of eyes.
Book about it. So Charlie's trying to tell her that it's a book about chemotherapy and suffering. And she says, it's a book about identity and forming your idea of who you are, how you act in the world, and the innate sense we have of who we are, and then that somewhat less innate, more mysterious sense of who we are, where our borders meet other people's borders, how other people perceive us, and how we perceive them perceiving us. I think it's really a book about being looked at and being seen and seeing yourself, both through your own eyes, other people's eyes, and learning to tell the difference between those two sets of eyes. So as a clinician, this makes me think, how can I see my patients better? And how can I appreciate what my patients see when they see me and when they look to me? How can I support my patients' full identity and personhood, even within the context of a time-pressured clinic visit? Just to further illustrate the point that identity is relational and situational. I'm going to bring in another character, Ann Patchett, who's a very well-known novelist who happened to be Lucy's roommate. They went to college together but didn't know each other in college, and she happened to be Lucy's roommate at Iowa, where they both did their master's in fine arts. And Anne and Lucy formed a relationship that both of them later acknowledged was stronger than the relationships that they had with either of their two siblings. And the relationship continued until Lucy's untimely death. But I think the reason I bring in Patchett here is to bring in another perspective of kind of how these clinical encounters are different depending on kind of who impact not just the patient, but also their communities. So Patchett writes, what surgery meant to Lucy and what it meant to almost everyone else were two different things entirely. For Lucy, a single surgery was more like a fitting for a dress or the rearranging of living room furniture. It was only a step towards something else. She never gave up believing that there would be a final moment, a last surgery, a point at which her, quote, real life would begin. The damage that was done to her at 10 would finally be made considerably better, if not right. Men would fall in love with her. No one would look twice unless it was to admire. She would be freed from the greatest burden of her life. If that was the reward, then the pain and inconvenience of more surgery was not an unconscionable price to pay. Also, Lucy was a good patient. She understood the politics and dynamics of hospitals. She could be remarkably sweet and easygoing with an IV tube hanging off either arm. She loved to be told that she was the most difficult case they had ever seen. Of course she was. She was the girl from the medical books. She was the case study. So here, these somewhat idiosyncratic reactions, unexpected reactions, I think, are the heart of what it means to see somebody as a whole complex human. So yes, Lucy suffered, and yes, Lucy had elements of tragedy to her life, but she also derived a lot of meaning from her role, not just as a poet and author, but also as a patient, and had meaningful relationships with hospitals and physicians for her entire life. So again, we're going to go back to Lucy on Charlie Rose. And here Charlie again is trying to kind of steer Lucy into a particular way of conceptualizing what happened to her. And Lucy resists it, which I find totally fascinating. I hope you do too.
Painful just to read what you went through. It is.
I know, it's funny. Chekhov, when he wrote the, I think it was The Seagull,
Yes.
baffled everybody. This is like this, czarist drawing room drama in which everybody thinks about killing themselves all the time. He baffled everybody by saying it's a comedy. And nobody really quite understood what he meant, and I never really understood until I wrote this book. And what happened to me was a life. And what I did is I took that life and I put it into a book. A book didn't happen to me. My life happened to me. And the thing is that when you read a book, it becomes representational of that life, which is very easy when you're reading somebody else's book. But as I was reading my own book, which was an abstraction of my own life, I began to see the absurdity of the entire situation, really. Not even the moments when I suffered genuinely. I'm not just counting that, but other people's interpretation of it. I've been on all these talk shows and people describe my life back to me and to the camera in the most tragic terms, and I just want to giggle the entire time.
Well, but do you giggle when you stood outside in the cold trying to get pneumonia because you didn't want to?
Oh, no.
You don't giggle when you say that,
I
do you?
didn't giggle
You don't
then.
giggle when all the things you did to yourself and to your body in order to get sick so you wouldn't have to take chemotherapy.
No, I don't giggle about those things, but it's interesting, again, because it's a book, and then this is an interview about the book, and it all becomes very abstract, which is very dangerous, too. It's very helpful, and I think in some ways true for me to have that distance about it, but it's also very dangerous if I try to get it at the time.
Okay, but I mean,
I think this is fascinating because, Charlie is really like asking her to suffer publicly. He's really asking her to perform suffering. And what she's describing, I think, is something that is so much more poignant than that, which is the idea that externalizing these experiences and creating them into the story can be healing and can allow you to have a very different perspective on what has happened to you. So a book didn't happen to me, my life happened to me. And now we're having an interview about that book. And so the levels of abstraction, I think she is able to articulate in a really profound way how healing that was for her. And Charlie, of course, just like wants a good somebody to cry on his interview, and she refuses to give him that, which I respect and admire. And that strength, this ability to process by externalizing, is something that can be beneficial both to our patients and to the clinician. And so here I'm introducing one of my treasured mentors from residency. He is a head and neck and reconstructive surgeon who was honing his craft around the same time that Lucy was having all of these experimental procedures. I should clarify, he never treated Lucy Greeley, but he was so moved by reading her autobiography that he then wrote his own narrative medicine piece in relation to a patient who had a similar story to Lucy's, but had the benefit of being born several decades later. He writes, two young women, identical disease, nearly identical surgical incursion to remove the tumor, one life cut short by the ravages of disfigurement and psychological trauma, the other hopefully back on the playing field. We remain keenly aware of the shortcomings of the functional aesthetic outcomes of the procedures we can give, but it's the very best we could offer. Our specialty was not ready for Lucy Greeley when she needed us, but given how far we have come, we are ready now. And what I read here in Mark's words is this profound sense of responsibility towards these patients and a personal regret that the technology just wasn't there in time for Lucy. And that sense of responsibility to one's patients is something that I found common in my mentors in head and neck surgery. Mark has been an incredible supporter of my own writing. He's someone that I send almost all of my first drafts to, and he helped me to understand my own writing as a lens that helps protect me from some of the more difficult aspects of my job. Helps me to protect my own interest in narrative inquiry and moral imagination, and honestly to protect myself from some of the more morally injurious parts of being a clinician and surgeon. And so I wrote about this in an essay for the New England Journal a few years ago. And in doing research for this essay, I learned that the lens that I use, so this aesthetic distance, actually has an etymological link with empathy, which I find very interesting because we are always talking about how, clinicians should be more empathic. How do we train clinicians to show empathy? And so the fact that there's a link between empathy and aesthetic distance, I find really interesting. So empathy comes from the German Einfühlung, which means in feeling, and that denotes an aesthetic ability to feel oneself in a piece of artwork. And I think that this in feeling decreases the distance between the self and the other. So it seems paradoxical that putting aesthetic distance between you and a patient may actually decrease the distance between yourself and that patient, but that's certainly the way that it's played out in my own life. And I think it's another way to engage your moral imagination. And certainly for me, and I imagine I'm not alone here, have found it to be an antidote to the moral injury that can sometimes accompany our profession. So back to our straightforward case. So this National Pathology Conference is coming up, and in talking with the pathologists, we revised the framing of this case. We included the original incorrect diagnosis, the surgical plan that was predicated on that diagnosis, and the consequences of that surgery on the patient's life, identity, and livelihood. The process of preparing the presentation, although it was not a narrative medicine presentation, was a processing mechanism both for me and for the patient. I still see her every 2 months, and our understanding of what we went through together continues to evolve. And happily, and I like a happy ending. They're not always happy endings, but in her case, her nerve function has entirely recovered. She's back at work and she's doing very well. But I think just this case really encapsulates a lot of these issues of identity, personhood, narrative, and the ethical inquiry that can go along with them. So I'll close with a few thoughts. I think we always intervene in identity as clinicians, whether we acknowledge it or not. We don't just treat disease, we encounter selves in transition. Sometimes we are the instigators or even the architects of that transition, and other times we're just the first to see or define it. So I'll close with an invitation to practice medicine as a true act of seeing, and to use narrative medicine tools to spark genuine curiosity about our patients' lived experiences. This poem is by a physician, William Carlos Williams. Asphodel, That Greeny Flower, is a very long poem. This is just an excerpt. And I've always found this particular excerpt very poignant at encapsulating why humanities, why narrative, why this is so important to our work as clinicians. He writes, "It is difficult to get the news from poems, yet men die miserably every day for lack of what is found there." Asphodel, in Greek mythology, is this neutral, vast, quiet region between heaven and hell. It's a place where ordinary souls went as they were wandering aimlessly, forgetting their past lives while surrounded by these ghostly, gray, pale flowers. And so I would just encourage us to think that even in our ordinary lives and even in our ordinary clinical encounters, they deserve a touch of poetry, pathos, and narrative inquiry. I'll stop there. I have some acknowledgements, which is Mark Ververis, my program director, Stacy Gray, my writing pals, Lisa Rosenbaum and Debbie Molina, Emily Silverman and the Nocturnists, which is an amazing narrative medicine podcast and live show. And this is my contact information and my website with full links to some of the essays that I referenced here. Thank you so much for having me today. I'm just thrilled to be here and I welcome any questions.
Thank you, Alessa. We do have some questions in the chat, but I'm wondering if we could tempt out a first question or comment here in the room. How are these reflections sitting with you?
This may be a little obtuse, but how do you know that Lucy died of an unintentional overdose?
Oh, that's a good question. So that's, I guess I don't personally know that, but that's how it has been reported. But there, yeah, so we don't know. She died of an opioid overdose.
Thank you. That was magnificent. You mentioned the elephant in the room, but I think we need to spend a little more time talking about it. And that's the issue of time. We have a decreasing number of caregivers. We have over increasing demand of care from the population. Population growth, it continues to take off like crazy. And I think all of us have this warm empathy that we want to extend to the patients, but where do we find the time in our busy lives? You've obviously been focused on this for some time, so I'm curious if you have any magic potion that's going to create additional flexibility in the care processes that we take care of patients. It seems like the patients think that we're like McDonald's. We can allow 10 minutes to run into McDonald's, get a Big Mac and a drink, and you get out of there. And if we don't get that, we turn in a quality report. That's really a bad McDonald's. They took too long getting my Big Mac. Thank you very much for making the trip. My sister lives in Chapel Hill, by the way.
Oh, we'll have to connect.
Right.
I'm looking
Thank
for
you.
friends. We just moved over there. So, okay. So yes, the elephant in the room, the time pressures of modern medicine and the kind of somewhat sometimes unrealistic expectations that our patients can have of the clinical encounter, that you're going to get this wise response within a 15-minute clinical encounter. So I think one of the tools that I use is an open-ended question at the beginning. So tell me what this has been like for you. I say that to almost every patient. And you'd be surprised, the reactions, the responses that I get are not half-hour narratives. It's like, it really can be as simple as trying to invite. So I guess going back to this sociologist, Michael Berry, who was interviewing the rheumatoid arthritis patients, and he was noticing that they were giving him so much more context in the sociology interviews than the physician interviews. I wonder if a physician had said, "What has this been like for you?" whether that would have opened up an entire gateway to this patient potentially being more seen in that clinical encounter. I think also the way my practice, a lot of times patients are coming in with a diagnosis already. And so I'm not having to do that work of explaining the diagnosis or making the diagnosis. And I will split up clinical encounters over multiple visits because I have that luxury as a surgeon. I see them for the preoperative visit. I see them in the preoperative area. I see them postoperatively. So I have this kind of longitudinal relationship where I recognize that not every area of medicine particularly like emergency medicine, you may see a patient once and that's it. So how do you bring in time and space to that narrative clinical encounter? I think that a lot of the work that we do here is not verbal necessarily. I think that patients can feel seen and understood if there's some silence in the room, if you're sitting at their level. I mean, these are things that people have talked about for years, but I find myself, even as somebody who's like very invested in this, rushing in certain capacities. And so slowing down enough to sit down, I think makes a huge difference for patients. And so finding moments, it's not finding an hour, right? It's not a therapy session. It's not a counseling session. And there simply is not an hour to do this. I think I've become a lot more comfortable in my clinical encounters also saying, I don't know about particular questions and saying like, I'm going to look into that later. And so leaving time for the interpersonal rather than like looking up something in the room or trying to figure out the answer in the room. I don't know if that's helpful at all. Okay.
So no magic potion, but
Certainly no.
you're going to keep working on that for us?
Yeah, my husband's a chemist, so we'll work on that.
So brilliant and articulate things. And so my question is actually, if you could think about something, it doesn't have to be now, but one of your quotes is, did we give up on a loved one or did we honor their dignity? And I bring that up because I work at the VA and we are always talking about this with our veterans, even last week. And if you have any thoughts on it, I'd love to hear them.
I think my thoughts on that quote particularly are just the importance of framing and how the way that we as clinicians frame some of these difficult moments can really resonate with the patients and the patients' families. I don't know, almost every like Hollywood interpretation of a clinical encounter, I am shocked at how terrible the physicians come off. And initially I was like, oh, they're just being lazy. But then I'm thinking, actually, this is probably based on some encounter that this person had with a clinician, and that's what they got from that encounter. So I guess, how can we indicate that we care more than and I think sometimes framing is like that, or taking the time to frame a difficult conversation can be like that. And again, it doesn't take a long time, but like acknowledging, maybe going back to your question also, acknowledging the difficulty of a situation. Like I often with my patients will say, I just want to get this out there. This is a very unfair diagnosis. I'm angry about this too. And then we can kind of move on to the clinical encounter. But I think that makes a difference because they tell me it makes a difference.
I just wanted to kind of dovetail on that. That's something my family and I recently dealt with. My mother passed away about 4 weeks ago after some time on hospice. And I feel like that was the hardest conversation. Having done rotations in hospice, that's my chosen specialty. When I match into residency, I ultimately want to do hospice and palliative. Very much seeing it as the dignity, the empowerment of how it isn't an ending of life, it's a transition of life, much like birth. It's that full circle transition. My sister had a very different view. It was a lot of that, we're giving up on mom. We're giving up. We're killing mom, she said to me. And I think our hospice nurse framed it so beautifully when she said, you know what, we're both going to sit down with your mom right now, bedside. And she said, because this is Marnie's life and this is Marnie's transition. And she gets to decide how that goes. She goes, we don't decide how we're born. Most of us don't even get to fully decide how we live. This is one time where she can have an honest say in this major transition in her life. And I feel like that language of taking it away from, I'm the physician, I'm the nurse, I'm making this decision, or looking at the children or the spouse saying, you make the decision, having the ability to put it in my mother's hand and have my mother look us in the eyes and say, this is what I want. And I think that was a really transitional thing for all of us too, in terms of acceptance and just kind of being on the same page.
Yeah. And I want to acknowledge the difficulty in the role that you played so you're playing multiple roles there, right? You're the daughter and you're also somebody who has insider knowledge of the medical profession. And that is incredibly difficult in the best of circumstances. Thank you so much for sharing that.
Thank you so much for that. These questions about how we frame things have me thinking about a study I read for our AI governance committee about the use of AI bots to respond to patient communications. And one of the things they found was that the patients felt that the AI communications were more compassionate than the communications from actual physicians. And I'm curious, first of all, could we teach those skills? Is that a teachable thing for our human colleagues who clearly are compassionate people, right? Are just not communicating that effectively. But also, is there a lesson maybe that we should take away from that?
That's such a great question. I think I read that study also. And I will also say that, like, in my own medical record now, when I respond to patient questions on my chart, there was like an AI prompt, and it's always like, I understand how difficult this has been for you. And so on the one hand, I feel like that kind of cheapens it, right? Like if a bot is giving more empathy than my words as a human who actually feels something, like on the one hand, I feel like, wow, what a cheapening of human experience. But on the other, I mean, I think if the patients are responding to it, and if that is a way, maybe the ends there are more important than my own feelings about a robot. I'm talking to my patients with more empathy than I do. Yeah, I think more work needs to be done in that area. I don't know that I have anything particularly profound to say about it, other than I read that study and was similarly kind of like, ah.
So we're going to try to be inclusive to the folks online here, and we have a couple of comments, questions from our palliative care team, one of which touched on AI. So thanks for bringing that up. So this other question I'll read. Love this talk so much. How do you see your role in impacting the culture of medicine? How do you bring this lens to your colleagues and to the healthcare system? So maybe less in on the patient, how we have those conversations, but more how do you take that into your work at UNC Chapel Hill or in other places you've practiced?
Yeah, so I think this is I always feel like I have to give a disclaimer, because obviously this is not like research qua research. This is not stuff that I can like publish. This is not original thoughts. These are just like things that I'm bringing in together that bring to bear on my own clinical experience. And so this being my like research interest, I think it helps, because there's not a whole lot of surgeons that are that interested in this, or that I shouldn't say interested in, because they are interested in it. It's that they don't get a lot of exposure to it. So I mean, I teach my residents. I do like narrative medicine reflection groups with residents from both my training program and other training programs, and I do try to bring in some of the impacts on story when I'm doing surgery, or when I'm performing a case, or when I'm talking to a resident about the case that we're going to do the next day. So I think I just try to live it. I know that sounds kind of lame, but I just try to like live what I feel is important. And I think that's important, not just for like, I think it's mostly I do it because it's protective for me, right? Like the writing stuff that I do, I would be doing anyway. And so it's nice that it's getting some attention and publication, but I would be doing it anyway as a reflective, protective mechanism. And so similarly, I think this is stuff that I do anyway. And so I try to just teach my residents to do it as well.
And maybe just a little bit back to the practical to wrap us up here. We're almost at time. Not to get into the historical complexity, the legacy of Charlie Rose, but I think I heard an audible gasp toward the end of seeing how he was pressing Lucy in that interview. Mindful of your response to Dr. Gilbert's question, that maybe we can start with a question, that not to sort of have an hour-long visit exploring these themes. How do we not be like Charlie? I mean, I sort of interact with a lot of folks in the residency and the clinicians who practice, and they worry about doing something badly and kind of entering into this different kind of conversation and doing it poorly. How do we not become Charlie in the way that the crowd really audibly gasped to see that?
Yeah, I mean, I think the problem with what Charlie was doing was that he was being incredibly directive. And like the whole purpose of this is to try to be, if a patient does not want to bring this into the exam room, that's okay. But I think leaving space for them to do so of their own accord, and acknowledging that there are emotional impacts of the diagnoses that we give, or the transitions that we assist with. I think acknowledging that there may be some emotional resonance there is the important thing, and being open to receiving it. Certainly in some of, I'm laughing to myself because I've certainly had this, not backfire exactly, but I've certainly had patients like not take me up on the tell me what this has been like for you. A lot of my patients are, septuagenarian, octogenarian folks that have had tough lives, and they're like, everything's just tell me what to do. No, that's fine. Just cut the cancer out. Get me out of here. Like I have an appointment later. And that's fine too, right? That's like, but that's another interaction I think that is equally valid as like a patient revealing some emotional distress inherent in their new biography.
Well, whether about the power of the abstraction or some of these concepts around witnessing biographical disruption, I'll take a lot from this talk, and I'm sure many of us will too. So let's thank Dr. Alessa Coliani.
Didn't see that there's